Hi, good afternoon to everybody who's joining us. A few things I want to talk about. First is the county has surpassed the state targeted rate of 10% of our population. We're into the 11% range now, moving to 12. We continue to increase our testing. Uh, we didn't set the state target as our target. Our target is to test as many people as we can possibly test. So we've met the state's metric, but we're continuing our testing. We are looking at what we can do to expand testing into the communities. I had a meeting with Latino communities leaders. I'll be meeting with African American community leaders to talk about what we can do to bring testing deeper into the community. But Dr. Gales will talk about the numbers so you get an idea about proportionality and what the test numbers actually really mean. We've done, wow, I think it's over 145,000 tests so far. And that's total tests. That includes some people who've been tested twice. We are in the 118 range, I think, for testing in general, for unique individuals. So that's where we are in the testing. We're experiencing the same issues, though, everybody else is experiencing. This is a national problem. It stems from underlying social inequities. The fact that we have these test results doesn't change the fact that people are getting sick for a reason. These are often cases, particularly in the minority communities, they are the so-called essential workers. I say so-called because they don't get paid like they're essential. They just go to work and you decide they don't have to, they should not stay home. But they're the people who are the most exposed, and they bear the greatest risk in this. So we're aware of that, and we're continuing to work on that. We discussed today that we are going to go to construction sites where we continue to see workers not working with masks or wearing masks around their neck, which is kind of useless. They maybe technically have the mask on, but it's not doing them any good. And we will be giving warnings, and then we'll be doing what we're doing with other business. We're going to shut down sites where people work unsafely, because these folks, if they're exposed to coronavirus, they're bringing it back to their communities. They often live in the more crowded housing in the county. So anything that comes back into those communities is more likely to have community transmission. So we're going to double down on that work. We're on the stage now of on-demand testing. So when you look at test results and you look at positivity rates for the months of March, April, May, and part of June, you're looking at results that came from the instructions that the only people who could be tested are people who doctors determined to be symptomatic. And so your pool was already starting with people who had symptoms. And so it's not surprising that you have higher results of positivity in that group. But as we've tested a broader population, and now that we're able to test anybody and you don't need a doctor's referral, we're going to see, and we are seeing, changes in the positivity rates because the universe of who's getting tested has finally been enlarged. Our average test positivity is below the state average, and it's lower than several of the other large jurisdictions in Maryland. And I'll just say what I tried to say before: we can't test our way out of health disparities. This tells us what the health disparities are. It does not provide a solution. People would still be getting sick, no matter how much testing we're doing, until we can deal with the transmission of the virus, where people get exposed and how exposed people are able to pass the exposure on to other people. But I continue to work with our health department, and our health department continues to work with the state health department to provide guidance on what we should be doing in the county. And we're going to continue to do that. We're going to improve the things we can improve, which means the deeper testing in the community. But we're also going to look at what else we can do in the long run in terms of how do you deal with disparities. And hopefully the state will partner with us, because this is going to require a deep look at what we do for healthcare and what we do for housing. Not just in the county, but in the state and certainly in the nation. We continue our support to individuals. I've continued to lobby the state on additional support, particularly on rents, and not necessarily directly to tenants, but certainly to use the landlords as a vehicle, because if the landlords get money to make up for lost rents, it's reasonable to ask them to forgive the tenants who haven't been able to pay the rents. And we know that it's a big lift to try to get the state, or at least the governor, to envision giving money directly to people who aren't documented. But I'm sure he would be concerned about landlords who, because they're not collecting rents, may wind up in default of their mortgages. So we're trying to come up with a solution to this problem. I submitted some budget changes. We took all the low-hanging fruit we could. We didn't cut programs. We focused on programs that we knew we weren't going to be able to operate. So even HHS got some cuts, but the cuts were not part of a decision to reduce programming in HHS. We were looking at what HHS is not going to be able to actually do that they otherwise would have done, and use that to provide the savings for this first tranche. We are waiting to see what the federal government does. There's more talk on the Hill about something coming out of the Hill before the end of the month. And when we know what that number is going to be, then we'll have a better idea of what deeper cuts we may or may not have to make.